Welcome everybody on joined us in. But we'll just give it a few minutes for other people to join, and then we'll start very shortly. Okay, let's start so we don't keep people too late. It's my pleasure to introduce Salma Abdelhady. I knew Salma from my visits to Egypt, a wonderful physician. She's a pediatric respiratory medicine lecturer and consultant currently in the UK, in the Great Ormond Street, learning a lot from them. And hopefully we'll have her back in Ain-shams. She is an Ain-shams University, an affiliated hospital in Cairo, Egypt. And her topic is childhood interstitial and diffuse lung disease. Do we need to routinely test for primary immune deficiency? So Salma, it's your show.
Thank you so much, Professor Samya, for the introduction. And I would like to thank Professor Ozge and Professor Lombardi for the kind invitation. So let me just make sure that the presentation is clear. Okay, hopefully you can see my screen.
Yes.
Okay, so our talk today will be, I'm Salma Abdelhady. I'm a pediatric respiratory medicine lecturer and consultant from Ain-shams University Hospital from Cairo, Egypt. And I'll be talking today about childhood interstitial and diffuse lung diseases. And I'll go through a few cases, and I'll be asking a really important question. Do we need to routinely test for primary immune deficiency in this cohort of patients? Okay, just to understand more, those patients, we received those referrals in our respiratory department at the Children's Hospital, and this is one of the largest tertiary hospitals in Egypt, and also to understand more about the healthcare system in Egypt, because it might be slightly different from US and the UK and Turkey. Patients in Egypt can present directly to a tertiary healthcare facility, but at the same time, there are some areas in Egypt that can be underprivileged from a healthcare perspective. So unfortunately, we received a lot of patients in a very late stage, and also there might be some limitations in the diagnostic pathway in interstitial lung disease. For example, we don't have access to genetic testing at the moment. So the cases that I will present today, they presented to us in the pediatric respiratory unit, and I followed these cases for several years as a part of my doctoral thesis, and this was the first collaboration between the pediatric respiratory unit under the supervision of Professor Imam Fouda and the thoracic surgery, Professor Ahmed Mustafa, and the histopathology unit, Professor Fatima Ghazel, the radiology unit, Professor Ahmed Osman, and also we collaborated with Professor Andrew Nicholson at the Royal Brompton Hospital. So we had two independent histopathology reviewers of the lung biopsy slides for a better diagnostic accuracy of the patients who had lung biopsies. So the common term that is known to most of the pediatric respiratory physicians is childhood interstitial lung disease. And this refers to a heterogeneous group of diffuse lung diseases associated with considerable morbidity and mortality. But actually, diffuse parenchymal lung disease is a more accurate term that has been adopted recently, as the disease can affect the alveoli, the airways, the blood vessels, lymphatics, pleural spaces, in addition to the interstitium. So for the more junior doctors, so to be clear on the definitions, to diagnose any infant or a child with interstitial lung disease or diffuse parenchymal lung disease, we have to exclude the common causes of diffuse lung disease, such as the cystic fibrosis, congenital heart disease, pulmonary infection, primary serious dyskinesia, before we diagnose the child with interstitial lung disease or diffuse parenchymal lung disease. And also, the patient should have at least 3 out of 4 criteria including respiratory symptoms such as cough, dyspnea, or exercise intolerance. Also persistent respiratory signs such as resting tachypnea, retractions, added sounds, digital clubbing, failure to thrive, or respiratory failure, hypoxemia, and diffuse abnormalities on a chest X-ray or a CT scan. So our first case is a 3-year-old female patient. She was referred to our pediatric respiratory clinic for assessment. The history that her parents told us is recurrent episodes of shortness of breath and high-grade fever that presented since the infancy. And she received multiple courses of antibiotics at her local hospitals, at her local service. Also, her parents were consanguineous. On the first presentation, her resting oxygen saturation was 60%. And she had a baseline respiratory distress, she had a severe failure to thrive, and she had a 3rd-degree clubbing. So at that point, we admitted her, and she had the initial workup, including full blood count ESR, lymphocyte subsets or CD markers, immunoglobulin test, tests for infections, and tests for collagen disease, and all of that was negative. Her echocardiography showed pulmonary hypertension with dilated right side, so her fan severity score was 5. So we've done a baseline assessment CT chest that showed bilateral diffuse areas of ground glassing with bilateral fibrotic bands and traction cysts. So as you see, her CT chest, it showed bilateral changes, diffuse changes. The areas of ground glassing, they are scattered across all of the lung fields, areas of fibrosis and atelectatic bands, and also areas of traction cysts. At the initial evaluation, because her resting oxygen saturation was 60%, she was already on home oxygen therapy, she was considered to be a high-risk case to undergo a diagnostic lung biopsy. And because we didn't find any underlying cause from the initial assessment, she was labeled as idiopathic or undiagnosed child, and she received the standard treatment for the interstitial lung disease, which is pulse steroids, and she was continuing on low-dose oral steroids, hydroxychloroquine, and azithromycin 3 times per week. Over the subsequent year, she was admitted 3 times with exacerbations for which she received pulse steroid therapy. And also, at the beginning of every admission, we do all of the check for infection, and we exclude infection before we proceed for pulse steroids. And actually, her baseline oxygen saturation improved to 87%. And at this point, we started the collaboration with the radiology department, with the thoracic surgery department for better diagnosis for these group of patients. And we referred her for a diagnostic open lung biopsy. So the most significant finding in the lung biopsy was the presence of striking granulomas with lymphocytic infiltration. I don't know if you can see my pointer here. So these are the appearances of the granulomas in the lung biopsy. Also, this is a closer look on the granulomas. There was dense lymphocytic infiltration, which is all of this infiltration that is surrounding the granuloma. So as I mentioned by the beginning of my presentation, that Professor Samya Nasr from the histopathology department from Ain-shams University Hospital reviewed the histopathology blocks, and also Professor Nicholson from Brompton Hospital. They reviewed the blocks and the slides separately, and the results were that there is a peribronchial, epithelioid, and joint cell granulomas, as we saw in the images. The granulomas were mainly non-necrotizing, although one showed focal neutrophilic inflammation. Occasional foci of organizing pneumonias. There was no evidence of vasculitis or evidence of malignancy. And also, as we saw in the image, there was a dense lymphocytic infiltration. Zane-Nilsson and Brucott staining, and the Brucott staining is for fungal infection. Both of them were negative, and their opinion that we need to primarily exclude infection, and also we should consider hypersensitivity pneumonitis and other causes of granulomatous lung disease, such as PID or other collagen diseases. And we also sent a tissue culture on the histopathology block, and it was negative for TB and fungal infection. And I would like to take that opportunity to clarify that there is a specific protocol and there's a specific guideline for doing any lung biopsy. So this requires a very meticulous and very clear communication and strict handling of the sample to get the best result. So the biopsy is not a simple procedure. Our patients, because it's in the pediatric age group and it's an open lung biopsy, so they take general anesthetic with all of the risk of the general anesthesia. So we have to get the optimum results because this is a risky procedure. I wouldn't say that it has more risk than any other surgeries, but because these patients have baseline pulmonary affection and most of our patients have baseline oxygen requirements. So we have to get most of the result from the biopsy as much as we can. Most of the surgeons, they like to take the biopsy from the right middle lobe and lingula, but actually the recommendations of the European protocols for the management of the children with interstitial lung disease advised against that, because sometimes most of the times actually the changes in these areas are disproportionate and may lead to faulty impression for the severity of the disease. Also, 20% of the sample need to be obtained first and sent for microbial cultures. And this is really important because opportunistic infection or very rare infections can give picture of interstitial lung disease. And 80% of the sample need to be fixed gently with 4% formalin. And this step is very important because if it's not fixed correctly, it can give impression of lung growth abnormality and can give false final diagnosis from the histopathology assessment. And also it's recommended to send a small part of the sample on glutaraldehyde for electron microscopy and frozen tissue for PCR. I just added that bit because sometimes the surgeons, if we didn't get clear on the communication, sometimes they don't for example, put the samples in the glutaraldehyde bottles, or sometimes they take the biopsy from unfavorable site. So from my own personal experience, there should be an MDT with the radiology, with the surgeons, with the histopathology doctors before we decide to send the patient for an open lung biopsy. So returning back to our case, we found granulomas in the open lung biopsy. And if you find any granulomas in the report of the lung biopsy, please stop and you have to follow the diagnostic algorithm for granulomatous lung disease, and you have to discuss with your immunologist. The differential diagnosis of the granulomatous lung disease is very wide, and there could be a very long list of investigation that you need to do for your patient. And you have to rationalize that based on the clinical presentation and based on the clinical assessment of your patient. The most important differential diagnoses for the granulomatous lung disease include infection, such as TB, non-tuberculous mycobacteria, fungal infection, parasitic infestation. Hypersensitivity pneumonitis, it's also a very important differential diagnosis to exclude sarcoidosis, Wagner granulomatosis, Church-Strauss, rheumatoid nodules, and CGD. All of these can be possible causes of granulomatous lung disease, and you have to systematically exclude them when you follow the diagnostic algorithm of the granulomatous lung disease. So we've done the microbiological tests on the tissue culture, and we also send the special stains, and we excluded infection in that patient. And then we started proceeding with the other test, and the DHR test, which is short for dihydrorhodamine test. It showed defective response, confirming the diagnosis of chronic granulomatous disease. And just a brief background information about chronic granulomatous disease. It's an inherited phagocytes defect. It's one of the primary immune deficiency genetic disorders. It's characterized by the defect in the oxidative burst, resulting in impaired killing of the bacteria and fungi, which result in life-threatening infection. And this leads to cytokine release and inflammation in different organs. And this leads to formation of multiple and development of multiple granulomata in different organs with the subsequent complications. Patients with CGD usually present with recurrent or severe pneumonia, but also the skin presentation, the skin manifestations, and the skin abscess is one of the very important signs in CGD patients. They also present with osteomyelitis, bacteremia, fungemia, and superficial skin infections. Other presentation include growth failure, abnormal wound healing, diarrhea, and infected dermatitis. And how do we diagnose the CGD? It's through the two main preliminary tests, or the dihydrorhodamine test and the nitro blue tetrazolium tests. And also we have to confirm with the genetic test and the molecular testing to confirm the specific mutation. And the treatment lines include prophylactic antibiotics, including trimethoprim, sulfamethoxazole, or other antibiotics, and also prophylactic antifungals, and also interferon gamma, and the therapeutic line is the hematopoietic stem cell transplantation. So in our patient, the DHR's test showed defective response, confirming the diagnosis of chronic granulomatous disease. And I have to send a very clear message that that patient's sole presentation was the pulmonary presentation. She didn't have any evidence of skin infection, and she didn't have any organ affection at the time of presentation. And that patient in specific, she didn't have any other systemic affection other than the pulmonary affection until she passed away. So I just wanted to clarify that this is rare, and the sole pulmonary presentation is rarely reported in CGD. So at that point, we asked ourselves many questions. What are the causes of interstitial lung disease in CGD? And is it sequelae of recurrent infection, or is it some sort of immune dysregulation? And what's next? Because when we treat interstitial lung disease, we give pulse steroids, because the pathogenesis of the idiopathic interstitial lung disease, it involves lymphocytic infiltration and immune dysregulation. So we give pulse steroids to decrease the inflammation. So that patient was diagnosed with primary immune deficiency. So we have to be very careful when we consider immune suppression. So what now? Do we give her immunosuppression, or do we just give her the regular treatment and the prophylaxis against infection? So we had to go back to the literature and see what's the information, what did the literature say about the interstitial lung disease in CGD. So to understand more about the pathology or the pathophysiology of the interstitial lung in CGD, it could be sequelae of recurrent life-threatening infection. So those patients get recurrent infection, and then the infection triggers inflammatory process, and this results in steroid inflammation due to increased expression of pro-inflammatory molecules in genes encoding polymorph nuclear cells. And it could be a sequelae of infection, or it could be steroid inflammation. That's what we found in the literature. So some patients develop what we call autoimmune granuloma, which is not associated with infection. And that was a very important piece of information that we got from the literature, that CGD is a primary immune deficiency. Patient get lots of infection, and the infection can cause post-inflammatory sequelae. But at the same time, the nature of the disease itself can lead to formation of autoimmune granulomas. These are not related to infection, and those patients improve on immunomodulatory therapy. And as I mentioned, that interstitial lung disease is considered to be a rare pulmonary complication in CGD patients, or at least that's what's reported in the literature to now. There's also another interesting line of treatment in CGD, and I dedicated a whole slide for that treatment, because that treatment has been reported to be effective in some cases of interstitial lung disease. So the interferon gamma is a known line of treatment in CGD patients because it augments the production of nitric oxide by the neutrophils, and it reduces the frequency and the severity of infections. But the reason that I mentioned the interferon gamma is that the interferon, this family of cytokines, were also investigated in various respiratory disorders, including interstitial lung diseases, respiratory infection, and in specific TB, and also interstitial pulmonary fibrosis. There has been some reports in adult population that there's been some cases with pulmonary fibrosis that are treated successfully with inhaled interferon gamma, but on the other hand, the randomized controlled trials didn't show a long-term benefit on the long-term progression of the disease. And unfortunately, I didn't find any data in the literature about the use of the interferon gamma in the interstitial lung disease in children who present with extensive fibrosis in specific, because you can use the interferon gamma to protect the patient from future infection, but we were stuck at the point we wanted to treat the patient with already pre-existing interstitial affection and pre-existing fibrosis and lots of fibrotic bands and traction cysts, as we saw on her CT images. So the further management for our case, after the specific diagnosis, we started her on prophylactic antifungal, azithromycin 3 times per week, prophylactic trimethoprim sulfamethoxazole, and we also kept her on a low dose of steroid, and also we kept her on the hydroxychloroquine. She had further 3 exacerbations after the diagnostic evaluation, and also that was a little bit tricky to manage because sometimes it's really difficult to confirm fungal infection. So during every exacerbation, we covered with antifungal, with antibiotics, and in a few occasions, we had to give systemic steroids because the patient didn't respond on the initial treatment. Unfortunately, her FAN severity score for interstitial lung disease at 12 months remained 5 with severe pulmonary hypertension, and she was not a candidate for hematopoietic stem cell transplant for many reasons. And the most important reason is that her baseline respiratory status was so poor, and unfortunately, that patient died in PICU with severe respiratory exacerbation. The second cases that I want to present today is a very complex case, and it took us a very long time to reach a specific diagnosis, but it's very interesting at the same time. So it's a slightly longer story, but that patient is, her story was really interesting, and we had to involve lots of teams from different parts of the hospital to discuss her case. So that patient initially presented to our hospital at the age of 5 years. She had a severe initial presentation with sepsis, and at that point she had a multi-system involvement. She presented with high-grade fever, productive cough, vomiting, diarrhea, pustular skin lesions in the legs and groins, and she was admitted to the pediatric intensive care unit, and there was evidence of pneumonia, myocarditis, pericardial effusion. So that was a striking initial presentation, and at that point we initiated a very aggressive investigations for immune deficiency that didn't show any positive or any specific diagnosis. She's the second child for consanguineous parents with history of exposure to birds and passive smoking. On all of that history was on the initial presentation. So as I said, the immune test showed elevated immunoglobulins, which is goes more with the infection. And she had a transient positivity for the P-ANCA, and her ANA and anti-DNA initially were negative. Her lymphocyte subsets and CD markers, they showed low CD4 and borderline natural killer cells. Because she presented with skin lesions and her initial presentation was severe, DHR test, the dihydrorhodamine test, was sent on initial presentation, and it was negative. Tests for TB were negative, and also she had a bronchoalveolar lavage, and we sent extensive tests for TB on the bronchoalveolar lavage, and all of the tests came back negative. After she completed her antibiotic treatment for the initial severe presentation of sepsis and after discharge, we followed her up in the pediatric respiratory clinic. And then she started to suffer from recurrent attacks of dry cough and exercise intolerance. At that point, we started investigating again. She had an echocardiography that was normal, and she had a spirometry that showed a restrictive defect. And her mother also reported intermittent self-limiting diarrhea. And I want to reiterate that that patient had the immune function test and the collagen tests repeated at least 3 or 4 times because she had a transient positivity of the p-ANCA, and we just wanted to exclude that there is an underlying collagen or an immune defect. After that initial episode of infection resolved, she had bilateral consolidations on her CT chest, and after she completed the antibiotics, long time after that, as I said, she followed up in the respiratory clinic, and then we repeated the high-resolution CT chest again to assess her current situation. We didn't have an explanation for her ongoing respiratory symptoms long after she was treated for the sepsis, and her high-resolution CT showed bilateral mosaic appearance with extensive ground glass opacities alternating with areas of air trapping, peribronchial wall thickening, and septal thickening. So as you see, the changes are extensive, bilateral on the CT chest. She had significant areas of ground glossing and areas of air trapping, giving this mosaic appearance. So at that point, she was labeled as a post-infectious ILD because we've done lots of investigation and we didn't find a specific cause for her ongoing respiratory symptoms. And she was admitted with exacerbation 3 times with worsening cough, tachypnea, desaturation. Her saturation were between 88 and 90, widespread fine crepitations on auscultation, and her symptoms improved on pulse steroids followed by oral steroids. She was very responsive to steroid therapy. So after she received the pulse steroids, she would improve dramatically, but on any attempt to taper the dose of the oral steroids, all of her symptoms recurred. So we tried to add on hydroxychloroquine, we tried to add on azithromycin 3 times per week, and she remained dependent on steroids. We could not taper the steroids, and this happened long time before I joined the respiratory clinic in 2017. So every trial to taper the steroids, she would deteriorate again and then be admitted for a pulse steroid therapy. So after 3 years of continuous steroid therapy with failure of tapering, she was referred for a diagnostic lung biopsy. We were stuck at that point. So we got that image from the lung biopsy. Also, striking granulomas and lymphocytic infiltration on the lung biopsy, but also the granuloma here, it's got neutrophilic necrosis, central necrosis. This is a more closer look on the granuloma. So this is the lymphocytic infiltration surrounding one of the granulomas. So we spent a very long time discussing the result of the lung biopsy for that patient. There was evidence of moderate interstitial chronic inflammatory cell infiltrate. Also, there was evident granulomas, epithelioid and joint cell granulomas, but these granulomas showed central necrotic neutrophilic inflammation. There was no evidence of vasculitis or malignancy. We done Ziehl-Neelsen stain for acid-fast bacilli that was negative, but the Drucott staining for fungal infection was positive. There was occasional fungal spores within the granuloma, and although the specific type of the fungal infection could not be ascertained, tissue culture didn't show the growth of bacteria on fungi, and the conclusion, whilst there was an evidence of fungal infection, it wasn't likely to be the sole cause of the feature because there was a very diffuse interstitial chronic inflammation. So the diagnosis that Professor Nicholson suggested is granulomatous lymphocytic interstitial lung disease spectrum. That was the image of the Drucott stain that showed evidence of infection, fungal infection or fungal spores with the Drucott stain. So what do we know about the granulomatous lymphocytic interstitial lung disease in children? This spectrum of diseases are reported in the literature to be a complication of common variable immune deficiency in adults. However, in children, the cases were not linked to common variable immune deficiency. So there was a very interesting published case series of children by Nadimi et al. And this actually happened in Great Ormond Street Hospital. Children were diagnosed with granulomatous lymphocytic interstitial lung disease, and they did not fit the common variable immune deficiency criteria. And they had more severe disease in comparison to adults. And they required intensive treatment with corticosteroids and hematopoietic stem cell transplantation. And the underlying pathogenesis was hypothesized to be impaired T cell function and subsequent impaired antigen handling. Those were the possible causes as the possible mechanism of the granulocytic lymphocytic interstitial lung disease. So after we found the granulomas and after we labeled her to have the GL-ILD spectrum, we've done some more tests. Repeat immunoglobulins, it showed elevated IgA. She did not fit the common variable immune deficiency criteria. And we repeated the DHR test again, and it was negative. After the biopsy, she was admitted 4 times. 3 of these exacerbations were due to infection, where she received antibiotics, and one of the exacerbation was a non-infective exacerbation, and she required pulse steroid. Oral steroids also could not be stopped due to marked deterioration in the clinical condition on steroid tapering. And then at that point, she started to develop pustular skin lesions with poor wound healing. And also that patient had, just a reminder, she had a severe initial clinical presentation, and then she had for 3-4 years only pulmonary symptoms, and then she started to develop skin symptoms later. So she had severe pustular skin lesions with poor wound healing. And then at this point, we had a further discussion with the immunology team, and they advised to send the DHR test, but also advised to send a specific test, which is the NADPH component, which shows which protein that is defective. And at that point, it showed deficiency in the P47. And after several discussions with the immunology team and with them, and also with the clinical pathology team, they mentioned that sometimes that the deficiency in the P47 protein, NADPH protein in specific, can lead to sometimes it cannot be picked up with a regular DHR test. So that's why we always have to send the DHR test with the NADPH proteins. So the progression of that patient, she had some autoimmune features. And as I discussed before, that patients with CGD can sometimes have the lots of infections, but at the same time, they can have some autoimmune features. And it's very difficult to balance the treatment for those patients, because sometimes you have to balance between the severity of the immunosuppression to control the autoimmune features, and also the same time that patients got primary immune deficiency, so you have to take care of the severe infections. Because she had very evident autoimmune features, rash, positive ANA intermittently, and recurrent admission with infective as well as non-infective exacerbation, we had to consider immune suppression. So she was started on a trial of a mycophenolate mofetil, didn't make any improvement, azathioprine at the same time, cyclophosphamide, no response on all of these lines. And also she received immunomodulator therapy, no response with progressive respiratory deterioration, dyspnea at rest, and continuous oxygen therapy. At this point, we had further discussions with the immunology team about the use of the Janus kinase inhibitors, the JAK inhibitors, and we even discussed the use of antifibrotics, and we discussed lung transplant. She was not a candidate, of course, for the hematopoietic stem cell transplant because of the severity of the lung condition. Unfortunately, after all of these discussions, we could not proceed with the JAK inhibitors or the antifibrotics. Even the antifibrotics, now it's only one trial that is running in for the use of antifibrotic in children. So we didn't have enough evidence to proceed in such a complicated case for these treatment. And unfortunately, the patient died in the pediatric ICU with respiratory deterioration. The third case, and this will be the last case. So the patient is a 7-year-old patient presented with a 2-month history of dry cough, nighttime sweats associated with significant weight loss, and he received multiple courses of antibiotics with no improvement. The patient was cachectic with diffuse fine crepitations, and CT chest showed right middle lobe consolidation in addition to enlarged mediastinal lymph nodes. At that point, his tuberculin test was positive, anti-tuberculous treatment was started, and he improved from a respiratory perspective. However, he still have noted significant failure to thrive and intermittent respiratory symptoms. So we've done some further investigations. His sweat test was negative CF genetics, and we have the CF genetics available in specific. All of that was negative. We've done some more tests and investigation to assess his respiratory condition and why he continues to have persistent respiratory symptoms long after he completed the treatment. And he had multiple bronchoscopies, and all of the lavages were negative for TB after that, after he completed 1 year of treatment. So on subsequent follow-up, the patient started to complain of attacks of dyspnea, exercise intolerance. Repeat CT chest showed interstitial affection in the form of ground glass opacity, traction cysts, and atelectatic bands. Further immune tests such as ANA, anti-DNA, and ANCA were normal. Immunoglobulins and responses to vaccination were also normal. And at that point, the diagnosis of post-infectious ILD was presumed, and he was started on steroids and hydroxychloroquine. Over 4 years, that's good. So just to recap, since I started this third case. So that patient was diagnosed with pulmonary TB, completed treatment, continued to have respiratory symptoms, reassessed again, and there was evidence of interstitial affection. And at that point, he was diagnosed with post-infectious interstitial lung disease, improved on pulse steroids, but then 4 years later, he started to develop skin manifestations in the form of recurrent abscess, in the form of recurrent skin abscess in the back, leg, foot, requiring surgical drainage. At that point, we repeated the CT chest again, and that was during an exacerbation, was during an episode of infection, so there was evidence of consolidation on the CT. The CT chest showed diffuse bilateral peripheral, central, and large patchy areas of ground glass opacities associated with septal thickening and fibrosis. There was also associated areas of air trapping, giving a mosaic pattern, abnormal bronchial thickening, traction bronchiectasis, and cystic changes, and also there was a large consolidative patch because that was done during an episode of infection. And also there was dilated main pulmonary artery suggestive of pulmonary hypertension. Because the patient presented with recurrent abscess, we had a further discussion again with the immunology team, and we've repeated all of the immune assessment again, and it showed low CD19 and borderline natural killer cells. And the HR test also showed a normal response, confirming the diagnosis of CGD. And despite being on antimicrobial prophylaxis, triple antimicrobial prophylaxis, he was hospitalized several times with infective exacerbation. And unfortunately, the patient died due to progressive lung disease. And for the interest of time, we have many more cases. We're presented with initial interstitial lung disease diagnosis, and several years later, they were diagnosed with primary immune deficiency. A patient who was diagnosed with pulmonary lymphangiectasia that was later diagnosed with CGD, a 5-year-old diagnosed with pulmonary TB, and later, 4 or 5 years later, diagnosed with CGD. One of our patients diagnosed with common variable immune deficiency, and one of our patients was also diagnosed with combined immune deficiency. My main message of the cases that I presented today is that the diagnostic algorithm and the pathway to diagnose the specific interstitial lung disease cause, or the cause of the diffuse parenchymal lung disease, can be quite difficult. But as a take-home message, you have to think of primary or secondary immune deficiency. The causes can be quite diverse, and it could be a very difficult diagnostic journey. But think of primary or secondary immune deficiency. So as a part of my doctoral thesis, I published our cohort of children, which were 22 cases, in the European Respiratory Journal Open Research, and you can find more data and more cases presented with child. And our center's experience, we reported 22 cases in that publication between 2017 and 2021. And we had 8 more cases referred to our center between 2021 and 2023. And 8 cases were diagnosed later on with primary immune deficiency, which is 26% of our total cohort of patients were diagnosed with interstitial lung disease. And this is a significant percent of the patients. And we also have patients from all over Egypt. So it's not just representative of Cairo, it's representative of patients from all over the country. The take-home message is early discussion with our immunology team, and they can help guide the investigation pathway. ILD genetics panel in many centers around the world, it's separate from the immune deficiency panel. So if you send the ILD genetics panel for your patient and you don't reach a specific diagnosis and your patient is still deteriorating and their ILD is still progressive, think of sending the immune deficiency panel and discuss with your immunologist. And child-specific diagnosis can help guide the management and avoid unnecessary intervention. And think a million times before you diagnose a child with a post-infectious child or idiopathic child, because a specific diagnosis can really help save the life of that child. Thank you so much.
Oh, thank you, Salma. We have about 12 minutes for questions. So if anybody have a question, please unmute yourself and ask the question. I think Professor Basil have a question. So if you want to start with that.
Oh, thanks very much. Excellent presentations. No, I was just wondering, as part of the ILD panel these days, we send as well the copper and STAT1 gene. And copper would be, I'm not an immunologist, but usually it's one of those interferonopathy. So yes. Has that been sent, the copper and STAT1 in these kids, or?
No, unfortunately, as I mentioned earlier, it was really difficult to send the ILD genetics. So we had one of our patients, the ILD the genetics panel sent, but unfortunately we couldn't send the genetics panel for most of the children. So we mainly depended on the lung biopsy for the diagnosis of these patients. And this was one of the problems that we had during the diagnostic pathway, that we didn't have access to the ILD genetics. But we're working really hard at the moment to get the involvement of other international centers to help us. And I really think the contribution in other international child network will help improve the quality of lives of these patients. But yeah, we considered sending the interferonopathy. There were other entities that we thought about, like the CV and the STING, but she didn't have any evidence of vasculitis as well. But unfortunately, no, we couldn't send the whole genetics panel for ILD. And that contributed, unfortunately, to the delay in the diagnosis for these patients.
Right. Any other questions? Comments? Okay. Right. That was an excellent presentation, Salma. Very proud. So good job. Just, make it back to Egypt. I miss you there.
Yeah, me too. I miss everything back in the respiratory clinic.
All right. Thank you very much, everybody. And thank you, Salma, and Asgi, of course, and Enrico.
Thank you, Samya. Thank you, Salma. And we are waiting for you in Mikor.
Yeah.
Everyone's eager to meet you. See? Bye-bye.
Thank you. Thank you. Bye-bye. Bye-bye.
Bye-bye.